Hi, everyone. My name is Ariana Thacker, founder and CEO of MoldCo, the leading virtual care clinic for mold-related illness. With me today is our founding physician, Dr. Ritchie Shoemaker, the godfather of mold. He's identifying the key biomarkers and the most evidence-based treatment approach in the space, and world expert Dr. Scott McMahon, the medical director here at MoldCo. Really excited to have you both on today's show.
Good afternoon.
Good afternoon. If you're the godfather of mold, do you sing and dance? I feel good.
No, who puts a horse's head in the bed? Do you know what I mean?
Whoa. So this is going to be a really fun show. Amazing. So yeah, what brings us here today is that we had a very successful Reddit AMA with both Dr. Scott and Dr. Shoemaker. So we're here to help double click on some of the most popular questions asked. And I'll start off lab testing. So what is the right playbook? And also would love to better understand what are some of the flaws with some of the current testing today, starting with Dr. Shoemaker.
Well, thank you for bringing the crew into my living room. It's a wonderful day, and talking about mold problems, especially laboratory studies, is extremely important. We have had a variety of decision-making processes that said we're going to include one test and not include another, so that all the tests that we use at MoldCo are ones that are necessary for good patient care. There are more tests that in the future we may be able to go around and include those. But for now, if we look at MSH and we look at MMP9, we look at VEGF, we're looking at the core group of labs. These are available through MoldCo to the users of the website.
Yep. All those tests are available on the MoldCo website. And Dr. Scott, what are some of the key flaws or at least limitations to what we see to the more popular tests or some of the other tests out there, such as urinary mycotoxin test and mycotoxin antibody test? Could you speak to that?
Yeah, of course. The problem with urinary mycotoxin tests are actually there's several. First of all, it's showing exposure. It's not showing that you have illness. The second is if you do have an elevated test for, say, ochratoxin, it doesn't say whether you got that from breathing it in your air or whether you got that from eating food. But perhaps the most fundamental problem is that, to my understanding, that there aren't any control values for these. In other words, normally when you offer a test, you do that test on 120 to 500 people that don't have an illness. And from that, there's a statistical method of determining what that reference range should be. And it's my understanding that that has not been done for these tests. So you really don't know what the normal range is supposed to be. So when you're being told it's elevated compared to what? You just don't know. There's a similar problem with the serum antibody testing for mycotoxins. It's purported that if you have an elevated IgG level, that's an immune globulin type G, that means that you have current exposure, and that's been written in some literature that I read. But the problem with that is there are no citations supporting that. It's contrary to what we were taught in medical school. In medical school, if you had an IgG that was positive, that meant that there was a remote exposure at least 3 months ago. And if you wanted to demonstrate that it was a current exposure, you had to test it again several weeks later. And if you saw that there was a fourfold rise, then that would indicate that, yeah, there had been current exposure. But a single IgG test just tells you that there was exposure some time ago, at least 3 months ago, and maybe years ago, and you can't take any more information from that. So neither one of those tests is really suitable for making a diagnosis. As opposed to the proteomic tests, the vast majority of these tests Dr. Shoemaker developed, the proteomic tests like MMP9 and C4A and TGF-beta1 and MSH, these all have very characteristic levels of up or down. Some people say none of these are specific to mold illness. That is true, but the literature shows that a combination of multiple abnormalities is highly specific for chronic inflammatory response syndrome and, to my knowledge, to no other illness. So getting a group of these tests and seeing that several are abnormal is very good evidence that you have a mold-based illness.
One of the additional problems with antibody testing is the lack of specificity of a given antibody. For example, you'll see reports of diagnosing Aspergillus or Penicillium and say, well, we've got an IgG. There are 300 antigens to which there are specific antibodies that we can measure in the lab, but available commercially? No, you've got an antibody. Well, which antibody and which antigen is it? It's not all of them. And then we have species to species differences of 300 antibodies. And we're going to say there is overlap of antibody production by species, by time of day, and all the other things that go into looking at immune responses. It's just is bad medicine to rely on antibody testing for tiny little molecules that aren't even big enough to make an antibody response.
Yeah, what are they called? Haptens?
Since
Haptens, yeah. So just to summarize, it's unclear with the test when and how long ago exposure happened, just that exposure happened. In the case of the serum antibody testing, for the urinary mycotoxin testing, it's unclear if it's ingested or inhaled. And furthermore, it's unclear as to what the severity of the illness too. It's just, is there exposure, yes or no? How bad is it? So it's not really answering an interesting question beyond the lack of controls and lack of validation, et cetera. So thank you for that. Several of the Redditors during our AMA were curious around, how do I know I'm in a safe environment and what can I do to clean my environment? Would you recommend any DIY cleaning solutions? And if so, when is that appropriate and how is that done? Starting with Dr. Shoemaker.
The most important issue is sterilizing the air that we breathe. If that involves a tool like an iAdapt Air that I'm particularly fond of, you can run those 24/7 and clear out significant volumes of indoor air. Add 2 indoor air, iAdapt Airs, you'll be clearing out more particulates. With 3, well, then you're really certain to go. But if there is problems with HVAC systems and you've got too much tonnage and you don't really remove water adequately from the air you breathe, you will have particulates. So you've got to look at what is adding to the environment that was possibly moldy by saying, what about HVAC or crawl spaces and air coming in through the crawl space? But specifically, if we steadily vacuum twice a week, ceilings and walls once a month, but then we also will have, for people with actinos, some way to go after this alkaline-liking organism. And if we use things like Fantastic, it may have a little bit of problem with those with chemical sensitivity, but they add to an additional burden for the poor actino trying to live. And if we have the combination of iAdapt Air, we have vacuuming, we have regular routine cleaning with Fantastic. We can look at small particle cleaning as one thing to do for mold and endotoxins, but for actinos, you need a little more of a different phenomenon.
Got anything to add? And also, what are your thoughts on vinegar and bleach?
I'm not a huge fan of bleach. It cleans off what's in the surface, but if you have mold growing in your sheetrock, for instance, the mold will come back because the mold is actually living below the surface. So I'm not a huge fan of that. I think vinegar is part of if you've just remediated, for instance, I think vinegar can be helpful to clean your walls. I'm a big fan of small particle cleaning that Dr. Shoemaker mentioned. I think that gets your air as pristine as it can possibly be. I'm actually talking with some people about what would be the benefit of doing small particle cleaning, not just after your remediation, but maybe on an every 3-month basis or an every 6-month basis to keep the air as clean as possible. And then you can deal with the actinos and the most important thing is to not get water damage. And if you get water damage, to get it cleaned up within 24 to 48 hours.
How much is a small particle cleaning? What are the recent prices you're seeing there?
It can be very expensive. I've seen, some companies charge $4,000. And of course, it also depends on the space of the home, the square footage. I I pay my father-in-law to do it, and I give him $1,000, and he does 2,500 square feet, and he's very thankful.
Pretty cool that you have that hookup.
Yeah.
How fun. Awesome. A common question we get at MoldCo, and I also saw glimpses of this in the Reddit AMA. What are your thoughts on natural binders? Where's the lack of evidence? And do they get patients better? And if so, over what timeline? Dr. Scott, do you want to start off with that one?
Yeah, I think natural binders can be used, but my experience is that they take a lot longer than either colesevelam or cholestyramine. My experience is typically 2 to 3 years for patients to get the results that we usually see with the prescription binders like colesevelam in 2 to 3 months. So to me, it's a pretty huge difference, and that's one of the reasons I never use them. Also, in reviewing the literature, I've seen that cholestyramine is being used in farm animals, and it's always superior over any other charcoals or clays or anything else that they gave to farm animals. Not as many studies in humans to really be able to distinguish, but just going on my experience of seeing a couple thousand people, I'd say that the prescription binders are much better. They're more harsh, so you have to be careful how you use them, but they're much more effective.
Yeah, absolutely. Dr. Shoemaker, you had mentioned that the field has moved largely away from cholestyramine towards colesevelam. Could you share some of the reasons why that is?
I think the most important thing is that we are now seeing a wider variety of healthcare providers taking care of CIRS patients, and MoldCo comes to the top of the list for this one. And basically, what we're saying is that we can get people into care quicker and have binder therapies in more rapidly without having to put up with the side effects of constipation and nausea and dyspepsia that the cholestyramine will use. I started with cholestyramine. I've used a lot of it myself. I have to tell you that anymore, I'm just cringing when I have to be taking cholestyramine again. Because, when you get old, I mean, attending to bathroom needs becomes more important. So it's been 3 days. Well, it must be cholestyramine after the. It's just not the right way to go. So colesevelam is just a fewer number of binding sites, and it will be better within 2 weeks than it was at 1 week, and better at 4 weeks than two. So you can use something less effective than cholestyramine over a longer period of time. Just want to mention with mycobind, which is dear to my heart, Ariana, you were here at my house. You could see the okra we've got growing out in the backyard, even in wintertime. And so, if we are looking at pods and seeds, which are the active ingredients in binding, and if you've got sludgy material from stewed okra, is that going to bind better than fried okra? And then we look at red burgundy or Clemson spineless, I mean, named for their basketball team, or anything. Sorry about that, but
The
yes, Clemson. It's a kind of okra, but you're better off eating okra than taking a pill. But there's such big differences of the quality of what you're getting depends on species and how it's prepared. So just to be careful with mycobind.
Yeah, I remember a conversation. I think this was back, you and I had it in 2023 of how many different species of okra there are and how the species is so important to the binding capabilities. So I thought that conversation was pretty cool. Dr. Scott, you mentioned that the binders like cholestyramine, colesevelam tend to be harsher, typically in more sensitive patients. What are you seeing as a way to minimize potential side effects or intensification reactions? And what can patients expect if they're more sensitive to these binders?
Well, I first have to harken back to one of Dr. Shoemaker's comments, and he and I are both Duke alumni, so the Clemson spineless, I just wonder what he thinks of UNC. So maybe they're the hornless. I don't know. No shade to anybody from UNC. But seriously, the cholestyramine, colesevelam can have some gut issues. Constipation is probably the most common thing that we see. And that can be treated in a number of ways with natural products, or if you have a history of constipation with whatever you use, magnesium, senna, other fiber. There are a number of different ways to treat that. And maybe the best way is just to prevent that and start ahead of time with whatever products you use to keep yourself continually going. We like to see that you're having at least 2 bowel movements a week, or even better, like 3 times, at least every third day. Obviously, the best goal is like once or twice a day, every day with nice soft stools, but not everybody is so blessed. And the second most common problem that we see is stomach upset. You can have nausea, feeling like you need to throw up, and occasionally throwing up. You can also have reflux-like symptoms. Historically, I've seen that those are fairly uncommon. You can use like an over-the-counter PPI to help with that. But most people, it only lasts for a few days and then it goes away, and they don't need any therapy at all. The biggest one that we see, or I should say the worst one we see, but it's not by any stretch of the imagination, the most common, is what Dr. Shoemaker calls the intensification. And that's where your previous mold toxicity symptoms just get worse with the first few days, or usually starting on like day 2 or day 3 of the binder usage. You may start seeing your fatigue is getting worse, or your cognitive issues are getting worse, sometimes stomach issues that you weren't having, or sometimes an exacerbations the ones you were, muscle aches and pains, just whatever kind of symptoms that you had before can get worse. At MoldCo, what we're doing is pre-treating patients with a no or low amylose diet and using omega-3 fatty acids at a high dose that help to prevent that from happening. Another thing that we do is we start the colesevelam at a low dose, and we titrate up. And again, the reason for that is because we want to try and avoid particularly the intensification. A few people will still have it, but for the most part, hydrating is enough to get you through it. For a few people, it will be so severe that you can't work through it. And for those, we just stop for a few days and start at a much lower dose and start working you up again. And almost everybody can tolerate that.
Awesome. Dr. Shoemaker, riffing on what just Dr. Scott just shared, could you share more about your experiences and the promise of low dose VIP in combination with these binders, and any other supplements, herbals, or other solutions you've seen to help quell some of the intensification side effects or help patients better tolerate prescription binders?
The low dose VIP protocol is one you'll find in the textbook that Scott and I wrote with Andy Heyman. It's chapter 10, and it is a fairly intensive uh, protocol to use to avoid giving full dose treatment right away. Interestingly, with Jeannie, we now can see that there's going to be a likelihood for environmental susceptibility to medications, whether it's drugs, whether it's chemicals, whether it's food. All these environmental instances of problems can be predicted ahead of time. You can use low dose VIP, understanding that we'll come back to higher dose VIP later. But the low dose VIP will block some of the environmental intolerances that we have. To date, it's been a godsend in that it really does make a difference in getting started. At full dose, we were using that to fix brain injury, for example, and take care of cytokine abnormalities. But just to get started, the very first week is important. Remember, some of these people that we treat are some of the sickest that you ever want to find. They're intolerant to many different things, and they're not making this up. They are having problems. And chemical sensitivity, I hate to say it, but I used to cringe seeing the MCS people come in to see me because I knew I had nothing to give them. Now that I've got low dose VIP, I welcome the MCS people because I know that I'm getting them better when most people won't. And it's such a gift to some sick people who have their lives rescued by a protocol of benign drugs.
Absolutely. I think VIP, and obviously I have some bias with MoldCo, is perhaps the most exciting peptide of our time, and at the very least, the most underrated of the peptides. So I'm super excited about VIP and the applications here, and perhaps even more broadly. Another common patient concern we hear is around the nutritional impacts of taking binders, especially for a prolonged period of time. Interestingly, there was a recent publication that used cholestyramine and colesevelam for PFAS and PFAS, so removing these toxic microplastics from the body, and it actually had pretty miraculous results. In just 1 week of cholestyramine, we saw a 23x reduction in stool samples before and after in PFAS and PFAS, and then in about 12 weeks for colesevelam, we saw roughly a 30x reduction in the serum samples. That was pretty cool, and that was compared to 2% reduction in controls. And the paper did touch on the impacts to nutritional levels in the body, and we saw none in that publication. So, Dr. Scott, could you share more about or help address this concern for patients around nutrient impacts while taking prescription binders, and when it does become a concern, if at all?
Certainly. I mean, we do know that both colestyramine and colesevelam are able to bind to some of the fat soluble vitamins like vitamin A, D, E, and K. And a lot of patients are concerned that that could be a problem. I think this is one of the perfect reasons why you should use colesevelam over, say, another like more natural binder, because we're only going to use it for 1, 2, 3, maybe 4 months, as opposed to using it potentially for 3 years. I personally have only seen a few patients ever need it more than 6 months. Most of my reading has suggested that you probably have to be on it for 8 or 9 months before it really causes a significant problem. And so we're never going to use it for that long. There have been very few patients in my practice when I had a practice that I did use for longer. They felt like they needed to be on all the time. We would always arrange breaks for them so that we wouldn't deplete all of those. So I don't think with proper nutrition that this is really an issue. We do know that some people don't have proper nutrition, however. And I remember a patient that Dr. Shoemaker and I shared who was 14 and she could eat 3 foods. That was it. She could eat 3 foods and drink water. Everything else made her amazingly sick. And low dose VIP made all the difference in her and was able to get her to a much fuller diet and to be able to tolerate medicines and other things that she had not been able to tolerate for years.
That's amazing. It's always sad to see the patients that come in only able to eat just a few food groups, and also on the other side of the spectrum, very miraculous to see the recovery as well when they're able to eat normal foods again. Amazing. Moving on from the binder conversation. So, Dr. Shoemaker, you announced your departure from surviving mold about 14 months ago. Where are you spending time now, and where can patients better educate themselves on the latest research?
What I have been doing is to focus on time consuming research. And if I fill up one bucket and empty another, it's looking at where does the time go? The time is always going to be spent. Um, Certainly, I've been responding to emails to Protein DX, the Genie website. I understand that MoldCo is going to have, hopefully about 100 publications that Scott and I have done or done singly that people can access. But for the new things, they'll just have to be looking at the MoldCo website more frequently than they would unless they're taking MoldCo therapies and looking at it every day, every day. But the issue is that I'm kind of spending more time on being with my family and more time doing independent research than patient care. But if there's some need, people can't reach me in my office in Pocomoke because Debbie Wader's still there, 43 years, still there, and answers the phone and will help out with patient questions as best we can. So I may be gone from surviving mold, but I'm not gone from the world.
Deb rocks. I mean, she's just a wealth of knowledge, and we're very lucky to have you at MoldCo too. Just having your ear and helping us train up our providers and setting the logic in our approach at scale. So thank you for all of your hard work since we started. Dr. Scott, what's exciting you most about the latest research? I see that you're on several of the more recent publications. Could you share a little bit more about what's getting published?
I mean, recently we published with Jody DeShore, Dr. Shoemaker and I, and another Brian DeShore published about autism, and we looked at PANS and PANDAS and the relationship with that, and Dr. Shoemaker and I had some data to contribute to that, and we recently published about mycotoxins and lab different ways of doing laboratory testing and the pitfalls of some methods versus others. And that's what we've been working on. What I see coming out of MoldCo is as we're aggregating more and more patients, we're going to be able to publish some really exciting numbers. I don't want to say them yet because we're still analyzing, but some really exciting numbers on how patients are benefiting with the use of colesevelam as a symptom reduction, improvements. It's really going to be exciting. I mean, I'm just like crossing my fingers and pinching myself because we're going to have some very large numbers and we're going to have some very exciting results.
One of the things that we have to pay attention to is what do people need from a virtual reality or a web-based site like MoldCo? It is improving and increasing access. It's improving quality and availability of research. We now are looking at treatment of CIRS, and just look at what we talked about was brand new applications. Here we are looking at Parkinson's. Here we are looking at brain injury. Here we are looking at environmental susceptibility. Here we are looking at VIP, letting people get by without trouble with uh, trouble with chemicals. The spin-offs, the expansion of the end of the illnesses that we can take out is just remarkable. And it's like every day I come to work and see, what's on the computer that's new this week. And MoldCo's bringing that to people so that we're expanding what we're doing by doing a good job of what we've been doing.
Absolutely. And we're going to organize and launch an education hub for patients as well. And we've started those early efforts mainly for our paying members and our resources portal. And we've more recently recorded videos with our clinical care providers. We're going to aggregate several of the publications in the field and help translate some of the more complex topics in the field so it's just more understandable by general population. Dr. Scott, you look like you're about to say something.
Well, Dr. Shoemaker touched on it. I mean, we're finding links between the inflammatory processes that show up in chronic inflammatory response syndrome. We're seeing links to that to amyotrophic lateral sclerosis or Lou Gehrig's disease, Parkinson's disease, Huntington's disease, and autism and other neurodegenerative illnesses. So we are pioneering yet again, Dr. Shoemaker. Here you are pioneering, these links, and
Absolutely.
maybe part of the solutions for these illnesses, or for at least a percentage of people who have these illnesses, and that may lead to prevention also. And so it's a very exciting time.
Absolutely. Two of the more recent publications, one having to do with triple positives, the other having to do with the pathway to actually recover MSH levels. Dr. Shoemaker, could you share a little bit more about the triple positives research and why that's groundbreaking?
What I do as a researcher is observe. And I observe and I see changes in labs. The labs that we get from Genie, which is not routinely part of MoldCo now, but I think it will be in the future. But we can look at the most sophisticated aspect of defining the physiologic disturbances that go with systemic illness such as CIRS. So that when I started seeing groups of CIRS patients having excessive amounts of cholesterol, which is a compound that has a lot to do with brain injury, that we found it was present in some groups and not present in others. And so the observation of an abnormality was then compounded because now we looked at blood components of coagulation, not the same thing as bleeding disorders that you get with clots and pulmonary emboli, but this is the more sophisticated interaction of lymphocytes and platelets and compounds affecting the microvascular clotting that goes on. And this has been something that we now know explains the vascular hypothesis of neurodegenerative disease. And we saw, hey, cholesterol is an injury process. Here's a clotting process. Does that mean we're clotting in the brain and getting microclots and microbleeds? Well, add to that, we've got cytoskeleton structures or tubulins that are highly involved in delivering nutrients and ions through axons from cell bodies into cell synapse. So that we've got three together. Talk about the three-headed man. What we're trying to do is to say, this is a comprehensive, all at one time focus that's new. It's new just because of observation of the abnormalities. And then you start to say, well, what happens if we fix it? And isn't that interesting? Now, at higher doses of VIP, we're seeing changes in brain injury that we never could dream of before. We've got two more papers coming out. One will be for Dr. Thacker to talk about.
Not a doctor, to be clear, but I was a patient with triple positives that did recover successfully with the higher doses of VIP.
And now there's 300 more just like you. And these, by a factor of 10 to 1, are the sickest patients of all. So that we may not be able to take care of them in the first round with MoldCo, but we identify a database that we can use going forward for the second round. This is just incredibly exciting. And now, since I can just speak to my own personal thing, my Parkinson's is so much better since I fixed triple positives that I started treating other people with this mechanism and collaborating with their physicians. This is just too exciting for words. Because here you read about Parkinson's. Well, there's no cure, but we can help reduce symptom duration and reduce the time that it takes to enjoy life. But I'm talking about cure.
Absolutely. And MoldCo more recently offered or offers high dose VIP. And we also will be launching the low dose VIP here shortly. Dr. Scott's on call right now. So, Dr. Shoemaker, could you expand a little bit more on why MSH was so tricky to recover if we didn't have an answer with that and what the promising solutions looks like in the field? Dr. Peg DiTullio recently published a paper, which I'm sure you saw, on the eradication of MARCoNS and how that's correlated with successful MSH recovery, as well as patients who are MARCoNS negative tend to have higher MSH levels. So I'm curious your thoughts on why is MSH so tricky, and why does treatment of MARCoNS work to increase MSH?
Well, this is a landmark paper that Peg has written with Christian Navarro. Uh, I think he'll get a lot of attention around the world because it has been the case that MSH did not improve with therapy. And back in 2000, I was petitioning the FDA for compassionate use of MSH, and they would not agree to compassionate use. And we had to do it all, no new drug development, which is $5 million plus. So I just gave up on having MSH improve. We looked at what the cytokines were doing. We fixed those and pretty much said MSH will be fixed another day when we have more time. Well, Peg has done it. She had 188 patients that she's able to show that MARCoNS making a variety of toxins is by itself something that will reduce MSH, just like it can increase some other of the polycyclic ether toxins. So MARCoNS is far more complicated than what we knew about. And it was interesting that the reviewer for Peg's paper from Frontiers in Medicine was Patrick Schlevert, who had reviewed my paper for the American Society of Microbiology in 2003, MSH and MARCoNS. But, he's still been after it, has been going after it. So I think we take a tip of the hat to Peg for her just doggedness in bringing successful therapy for something we had to have. We knew that VIP didn't cause a rise of MSH. We thought that might be the case, but she's just been sticking with it and measuring for a longer period of time. So, like I said, the more people we have, the more researchers we have, the more information we're going to find. And what you're bringing to the CIRS world is hope. I hear my saying, I haven't seen MSH fixed, and Peg says, well, I can do it. And here's Jody DeShore saying, she can fix autism and does. And that paper has been published. And then now we can come along and say that treatment with non hormonal things and non-binding things, so like urinary mycotoxins, is something we can say goodbye to because we've got something better to bring in its case. People won't be reaching out for something to take that doesn't work. So it's exciting to see the growth that we're having. But truly, as an old man, I was just smiling deep down because I helped train Peg, and not that I take any credit for what she's done, but it is just like a father seeing their child ride a bicycle for the first time. Goosebumps and thrill of the chase. So a happy day for Peg, and thank you very much.
Absolutely. Peg is a MoldCo advisor as well. We're speaking on behalf of the clinical team. We love Peg. She just helps us so much in so many ways and brings so many deep cuts and pearls to the table. So we're a huge fan too. Dr. Scott, anything else to add to the MSH conversation? Perhaps touching on the treatments that were mentioned in the paper and what MoldCo treatments include as well.
When I first started seeing these patients and I was talking very frequently with Dr. Shoemaker, I was seeing patients on a monthly basis and I was doing lab tests on a monthly basis. And it didn't take very long to realize that MSH doesn't come back in most patients. And that's a frustration because MSH is such a central portion of the biotoxin pathway and it's involved in so many of the different symptoms that people with mold toxicity get. And so to see that PEG is having that kind of success, it brings hope not just to the patients, but it actually brings hope to me too, that we can impact these people in a better way, in a stronger way. I have had some improvement in MSHs with VIP, uh, but not tremendous. And so I think this is an avenue for us to be able to go down. And I'm sorry, and not only that, but yeah, in the treatment of MARCoNS, I mean, we're using the same kind of therapies that PEG has published on now at MoldCo. And so I'm anticipating that we'll have similar results that she did, and we can validate her study and change care for people around the country.
Yeah, absolutely. And I think PEG just continues to be on the bleeding edge of so much happening in CIRS. So I'm really excited to track future publications from her as well. Kind of a spicy question. Why doesn't insurance typically cover this indication? I know there's some providers that bill against the whole host of symptoms. At MoldCo, we typically see on average patients with 27 symptoms coming in at the intake. But why isn't there insurance coverage, and is there any hope of getting insurance coverage? Starting with Dr. Scott.
Yeah, I took insurance for 9.5 years. And I mean, insurance is usually a game and you have to figure out how to play the game better than the insurance companies. So I did it for 9.5 years and I was going bankrupt. Uh, and the problem isn't that insurance doesn't cover mold-related illness and the very symptoms because there are like 20 different diagnoses for every patient, and you can only list 6. And so if you're thoughtful about the 6 that you list, it's no problem at all. The problem is that you're giving these people 2 hours of your time, and the third party insurance system doesn't reward that. They reward 5, 10, 15-minute visits, and they reward procedures like surgeries and endoscopy and colonoscopies and things like that. That's what they pay money for. But you have a truly complex patient like what we usually see with CIRS patients. And you spend 2 hours really kind of going through and discerning the different aspects of what their care needs are. And they don't pay for that. They pay very small amounts. And you can't pay your staff with what they pay. And that's why I don't currently know any doctors in the United States that take insurance for this illness because it's just too complex. It takes too much time and the reimbursement is inadequate, which is a real shame for these really complex patients that actually could be doing much, much better. And then another problem is that some of the medicines that we use are compounded. And generally speaking, Medicare doesn't pay for compounded medicines. And if they don't pay for it, a lot of the third-party private insurers don't pay for it either. And so it ends up becoming a cash burden for patients. And some people I've heard say, like, you have to be rich to get this illness. But the problem is that's not true. It's anyone can get it. And the lower your socioeconomic status, the more likely, because you get this from your house and you're less likely to do maintenance or have the resources to do adequate maintenance or take care of the water damage or get an expensive remediation. So it's really lined up against people. And that's why most doctors don't take insurance.
There's some cynical aspects to the answers of why insurance companies don't support CIRS. At the risk of using hearsay, there was one deposition that I was being attacked by the defense attorney. And he goes, you're the most dangerous man in America.
Whoa.
And I said, well, thank you very much. Have a nice day. And the reason I was the most dangerous man in America is that I would take people who had illnesses from housing, and capitalism is based on investment in homes to a certain extent. And if we were able to show that it was expensive to put up new housing or expensive to fix housing, then the cost could be controlled by making sure that no one could use a code that says we're doing a good thing. Now, we've had paper after paper after paper published over the years, and the question about a actuarial definition of what's important in medicine is not the same as what's important in medicine. If we have CIRS, or systemic inflammatory response syndrome, accepted, chronic inflammatory response syndrome is not. It's just it's an SRS. It's chronic fatigue, and we're fixing brains and fixing brain injury, and that's not something that's worthwhile. When we looked at the ICD-9 and ICD-10 code book, looking for illnesses and diagnoses that were not in there to refute the fact that CIRS wasn't in there because it was a wrong diagnosis, we found literally hundreds of illnesses that were present and accepted routinely, but they didn't have the politics and the politicians with their basis in what is true for the American public. We would fix the wet buildings. We would fix the people who could get care, who couldn't get care. The old expression of "get out of my emergency room" is a short way of saying Gomer. When I trained at a good institution, people that had 30 symptoms in the emergency room again were Gomers. And get out of my emergency room. You're wasting time. Let me have the sick people come. Well, they were sick. We weren't smart enough to figure out what they were telling us. They were telling us with their heart and their soul that they have a systemic problem that's due to inflammation, that's due to metabolism, that's due to hypometabolism, and it's due now to triple positives. So we've got 4 big issues, and we were not smart enough to figure it out. And just look what we've got now. We've got people who can call on MoldCo for trivial amounts of dollars compared to what it used to be. It used to be $1,500 was what a new CIRS patient would have. There's some doctors that have more expensive programs than that. But the issue is that if we put patient care first and can spell the word compassionate and add care to that to make a phrase, that's our motto. And compassionate care is what MoldCo does. It's what we have to be doing. And sooner or later, whether it's with Robert Kennedy saying we're going to have a war on chronic fatigue and chronic illnesses, now's a good time to start with CIRS. Because when you fix CIRS, you fix most of the spin-offs from CIRS in addition to CIRS itself. I'll get off my high horse, but it's time we started caring for patients.
I can't stop. Yes, Dr. Shoemaker, you were smart enough to figure this out. Thank you.
Thank you.
And then I'll add to that. I had a patient once. She was an adult, and she told me she had pediatric CATCH syndrome, CATCH. and I'd never heard of it. I'm a pediatrician, I'm board certified. So I went and I looked it up. There are 150 reported cases in the world. At that time, there were like 3 publications, and they had an ICD-10. This is a disease I'd never even heard of as a pediatrician, and they have an ICD-10 code. And here we have thousands of patients in the literature, over 40 publications in the peer-reviewed literature, and we're still waiting for a unique ICD-10 code for CIRS. We have biomarkers, we have treatment, we have systematic reviews, we have randomized controlled trials, we have imaging, we have visual contrast sensitivity, we have transcriptomics. All of this stuff has been elucidated and published.
Now, how many biomarkers are there in chronic fatigue syndrome?
0.
Well, if you don't have any biomarkers, how can you have a ICD-9 code or a 10 code?
Yeah. It took them 28 years to get one.
Yeah, and we have thousands in the literature, and we actually publish an economic impact report that estimates 25 million Americans severely impacted and 50 million Americans moderately impacted. Furthermore, there's an ICD-10 code for being bit by a turtle. It's about time there's an ICD-10 code for mold-related illness. I'll say that much. Uh, we're at the closing time now for this webinar. Any final thoughts, starting with Dr. Shoemaker? Words of hope? Anything we didn't cover that you want to share? Any additional thoughts for the audience?
Well, it's one of the things they used to do with patients, because by the time they got to poke them up, they didn't come in on the main highway. It was just kind of off the beaten track. And usually the couple family members in the exam room, and a lot of jargon and a lot of talk, and I talk too fast anyway. But what I left them with was the story about Pandora's box. And have you heard of Pandora? Yes, Greek mythology. And Zeus made her take care of the box that her brother had been accumulating, and all the ills of the world were closed in the box. And she says, whatever you do, don't open it. So as soon as they turned their box, as soon as they turned their back, she opened up the box. And all the flies and mosquitoes and hornets and all the bad things came out. At the very bottom, there was a butterfly, and just soft, gentle, fresh out of the chrysalis, and that was hope. So at the bottom of the box, that's where hope is. And hope never, never, ever should stop being part of what people leave the office with. If I left people without hope, then I didn't do a good job. If I left people with hope, I did do a good job. Scott's real good about giving people hope. And Ariana, and maybe I'll say your name right, Ariana, you're bringing hope to the masses, and that's such a beautiful thing. So I thank you every day for that.
Thank you, Dr. Shoemaker. We love you so much. We really appreciate your work. Thank you. Dr. Scott, any closing words for the audience?
I think within Pandora's box that we found copper and dithiocarbamates. That's an inside joke for Dr. Shoemaker.
Good job.
I think that, I'm not a salesman. I believe in the things that I believe in, and I believe in MoldCo. I think, to me, this is an answer to prayer. When I was in practice, I had to charge large amounts of money to keep the doors open. They had 6-month waiting lists before new patients could get in. And I understood that we were just treating the tip of the iceberg of patients with chronic inflammatory response syndrome. And for years, I prayed, what are we going to do with all these other people when awareness hits? Because I knew at some point awareness was going to hit. And then instead of being thousands of people looking, there eventually would be tens of thousands and eventually millions of people looking for mold diagnosis or mold awareness, mold education, mold treatment, whatever they could find. And Ariana, I think you came at just the right time and created something that can meet the needs of these millions of people and bring the hope that Dr. Shoemaker was alluding to. When I first started in this, it was not uncommon for patients to have seen 20 or 30 doctors, most of whom thought they were crazy, suggested they get psychiatric care, completely dismissed them, gaslighted them in their own ignorance. And to now know that there is something that's available to give these people hope and care, it just warms my heart. So thank you for everything you do, and thank you, Dr. Shoemaker, for tackling this for the last 30 plus years.
It's days like this make everything all worthwhile,
That's so sweet. Just want to say I can't imagine building this without both of you. Thank you for your years, decades of incredible research, for believing in us very early on, and just continuous contribution for patients. And as Dr. Shoemaker said, compassionate care. I think that rings true for our entire team. Our entire team is obsessed with getting patients better and keeping everything we do at the lowest possible price point without sacrificing quality, and just supporting patients at large. So if you ever have any feedback for us, we'd love to hear it. We're constantly running customer interviews and meeting with folks and listening to what patients need. So you can send us an email at support@moldco.com. And we also have a number of free or at cost resources on our website too. So we have our free assessment diagnosis, but it's a free educational tool to help assess if you have the common signs of mold exposure and health issues that result. And we also have our starter panel, which is only now $56 at cost to us, and it includes the 3 top biomarkers that are frequently off due to mold-related illness or CIRS. So that's MMP9, MSH, and TGF-beta1. Amazing webinar. Thank you both for taking the time. We're excited to share this with the communities.